Good afternoon, everyone. This international seminar on liver toxicity and steatotic liver disease has invited a speaker today, who is Luis Antonio Diaz, who is assistant professor at the Department of Gastroenterology and Hepatology, University of California, San Diego. He's really an expert in steatotic liver disease, in muscle D, but also in alcoholic liver disease. The topic we going today is the border associated liver disease and drug-induced liver injury. So big thanks, Luis Antonio, for accepting our invitation. You can start with your presentation. Thank you very much.
Thank you, Dr. Andrade, and it's such a honor to stay here sharing some ideas. And today I'll speak about steatotic liver disease, and I will mainly focus in the borders between the muscle D and drug-induced liver injury. And to start, I have to make the disclosure that I'm a transplant hepatologist, so I'm a clinician. So most of my research has been focused in translational and clinical research, but for sure, basic science is extremely important in this field. And for today, I would like to highlight the clinical features of muscle D, what we really know until October 2025, and also highlight how muscle D can alter drug disposition and susceptibility. That's an important topic for the drug development, but also for the potential risk of some medications, and to provide a practical framework to distinguish muscle D activity from drug-induced liver injury. And finally, I would like to discuss about some provocative insights in terms of magnetic resonance imaging, but also in non-HLA genetic risk, especially talking about the PNPL3 genetic variants. So probably most of you are aware that liver disease, it's a major cause of premature death, especially in individuals with an age below 50 years old. And alcohol, but also obesity, diabetes, and viral hepatitis are the leading risk factors for chronic liver disease. So the population exposed to liver disease as a baseline comorbidity, it's extremely high. And we will check the epidemiology in the following slides. But today we're talking about steatotic liver disease. And probably you're also aware about the 2023 criteria, where steatotic liver disease was redefined in 3 major subtypes: muscle D, met ALD, and ALD. And other specific steatotic liver disease groups, including drug-induced liver injury. It's important to clarify that these criteria were arbitrary and were defined by Delphi consensus, and not only based on evidence. So you can notice that there are some caveats in this definition that we'll address in the following slides, especially for drug-induced liver injury, but also since I'm a clinician working mainly in muscle D and ALD field, I have to acknowledge that the thresholds of alcohol use that are described in this definition are probably a little high. And we know and we are aware that even lower levels of alcohol use can induce liver disease in the population with steatotic liver disease. And they define muscle D specifically in those individuals with low levels of alcohol use, but also they define the cardiometabolic risk factors criteria. These are the same criteria from other conditions like metabolic syndrome. But the difference with metabolic syndrome is that they are considering at least 1 out of 5 criteria versus metabolic syndrome that considers 3 out of 5. And this is another caveat of the definition, because we can speak about muscle D even if we only have a mild increase in waist circumference or BMI, or a mild elevation of triglycerides. So probably this is important to have a sensitive definition of muscle D, but unfortunately can difficult the identification of other steatotic liver disease subtypes. And regarding the epidemiology of steatotic liver disease, we know that in the US, at least 38% of the population, especially adults, have steatotic liver disease. And most of them will have muscle D in around 32%, and a smaller fraction will have met-ALD and ALD. But it's important to clarify, at least in this study, they identify a prevalence of 0.3% in the overall adult population of the United States, with a cryptogenic on other etiologies, including drug-induced liver injury. And it's important to also notice that met-ALD and ALD are probably underestimated. In fact, some studies from Alexander Craig and other colleagues from Europe and other regions have estimated an underreport of alcohol use up to 10% in clinical trials and up to 55% in clinical practice. In the same way, probably the same phenomenon happens with drug-induced liver injury. We're not looking at these patients, so probably the prevalence of steatotic liver disease due to drug-induced liver injury is underestimated in the overall population. And we can recognize multiple mechanisms involving the onset and progression of steatotic liver disease, and we can identify baseline risk like your genetic risk, but also unhealthy lifestyles and dietary patterns. And these risk factors and the comorbidities like obesity, insulin resistance will promote the development of steatotic liver disease. And the key pathophysiological aspects here are the insulin resistance and the adipose tissue, because insulin resistance induces an excessive lipolysis and release free fatty acids to the bloodstream, arriving to the liver. In contrast, alcohol can interact with these mechanisms, but also have direct effects in the adipose tissue, but also in the liver, promoting de novo lipogenesis. And other mechanisms, including steatotic liver disease due to drug-induced liver injury, can interact in these different mechanisms. If we make a zoom of the most relevant pathophysiological mechanisms of steatotic liver disease, we can identify the abnormal lipid metabolism and also a different immune response that modulates the inflammation and fibrosis progression, and that can interact with the intestinal dysfunction. But also, it's important to notice that a relevant mechanism, it's the hepatocellular damage and death due to DAMP's release, endoplasmic reticulum stress, and cell dysfunction, and other related mechanisms like hepatic stellate cell activation that are potential targets for a steatotic liver disease due to drug-induced liver injury. Most of you are aware about the natural history of steatotic liver disease, especially muscle D. And we know that individuals that develop muscle D probably will take around 15 to 20 years since they start with the disease until they develop cirrhosis. So this is a very, very slow progressive disease in the most of patients in the overall population. But if we think about steatotic liver disease, we always need to think about the main drivers of liver disease. And this include the cardiometabolic risk factors. And I will show you how these factors interact in the progression. Also, alcohol use. If you drink more, you will have a higher risk of liver disease, but also the genetic risk in this population. And this is a manuscript from David Martí Aguado, a close friend from Spain. And he made this study assessing the role of cardiometabolic risk factors in alcohol use in the steatotic liver disease population. And he included two groups, people from Spain, but also the NHANES population from the US. And he observed a relationship between the number of cardiometabolic risk factors, but also with the levels of alcohol intake in this population and the risk of liver fibrosis. So I would like to speak now about the genes involved in the dual etiology, and particularly in PNPLA3, because this is a genetic variant that usually it's involved in the release of or basically metabolize the triglycerides and promote the storage of lipids in the hepatocytes. So if we see the overall population of that are affected by this genetic variant, we can notice that the Latin American population have very high allele frequency of the high-risk variant of PNPLA3. And in Europe, these differences are very heterogeneous. And if we focus in the UK Biobank, we can notice, sorry, someone write that cannot see any slides. Can someone confirm that the slides are correct?
I am seeing all the slides you are showing. So
perfect. I appreciate it. Thank you. So regarding PNPLA3 and the interaction with the cardiometabolic risk factors and alcohol, I really like this study from the UK Biobank because you can notice how these variants can have an additive effect promoting the risk of cirrhosis over time. And if you see individuals with excessive drinking, obesity, and are homozygous carriers of the PNPLA3 variant of risk, they have a incidence of cirrhosis in around 8% at 10 years follow-up. But if you take off one of those three factors, PNPLA3, it's not so easy, but if you don't have excessive drinking or you have a weight loss, your risk of cirrhosis will decrease up to 4 times, being between 1 to 2% at 10 years of follow-up. If we focus in older outcomes like hepatocellular carcinoma, we can see the same phenomenon, and same for liver-related mortality. So your genetic background seems a relevant factor that modulates your risk of progression over time in the overall steatotic liver disease population. And this is a study that also used the UK Biobank and also the Michigan Genomics Initiative. And they identified that individuals with indeterminate risk by FIB4, but if they also have diabetes and also have a PNPL3 high-risk variant, they should be considered as a high-risk population with a same incidence of progression than those with a FIB4 over 2.67, sorry. And this figure represents the same that I mentioned before. So in green, you can see individuals with an indeterminate FIB4, but also with diabetes and homozygous for the genetic variants for PNPL3. And you can notice that the progression to cirrhosis was even higher than individuals with a high risk by FIB4, but no the diabetes plus the PNPL3 homozygous carriers for the high risk variant. And this phenomenon was replicated in the UK Biobank. And at the UC San Diego, we also conducted a study trying to determine the natural history of steatotic liver disease, mainly muscle D, by assessing the PNPL3 genetic risk. And we create models, we create different assessment, including more genes, less genes. But basically, if you have a PNPL3 GG condition, so if you're homozygous for the high risk variant, your risk of liver fibrosis is higher, even if you have or not have diabetes, even regardless the body mass index, age, gender, race, and ethnicity. So we can notice that PNPL3 can modulate the natural history of someone who develops steatotic liver disease. And in muscle D, this change appears at 40 years old. So after 40 years old, if you are a PNPL3 GG carrier, your risk of fibrosis will be higher. And there are other variants, including TM6, SF2, and HSD70V13. They are involved in other mechanisms. For example, TM6, SF2 have different variants, but the hepatic variant has been linked with a decreased hepatic VLDL expression, producing an increase in intrahepatic triglyceride content and steatosis and steatohepatitis. Same for HSD17B13. The HSD17B13 is a protein that catalyzes the conversion from retinol to retinaldehyde. And when you have a genetic variant in HSD17B13, you have a loss of function of this protein, this enzyme, and retinol accumulates and have protective effects, including the stellate cells, decreasing the fibrogenic mechanisms, the inflammation, and the activation of the cells. And some granular data assessing the combination of PNPL3, TM6, SF2, and HSD17B13 have shown that they can also explain the risk of liver fibrosis and potentially their progression over time. But probably in the Americas, that benefit in terms of prediction is lower than PNPL3. So we review several mechanisms of liver injury and steatotic liver disease, and how these mechanisms interact in different ways to observe hepatic steatosis in clinical practice. But what happened in those individuals who already have muscle D and are taking medication? Well, the risk of drug-induced liver injury in the overall steatotic liver disease population, it's not so clear. There are some studies that include cohort with pros and cons that can demonstrate a higher risk in the muscle D population, but we still need some information to confirm this risk. For example, in this study, including 248 patients from Italy with no advanced liver disease, they compare a group of people with hepatitis C with another with muscle D. And they identify a higher risk of drug-induced liver injury in the muscle D group. And this risk was fourfold the risk in the hepatitis C cohort. As I mentioned before, the data available, it's not so granular to say that all individuals with muscle D are at higher risk of drug-induced liver injury, but for sure, it's something that deserves more attention. Other study published a few years ago also include different cohorts from the US, and they stratify the exposure to the 10 more common medications of drug-induced liver injury in the US. And they identify that in the population with muscle D, the risk of suspected drug-induced liver injury was also fourfold times higher, being 0.8 compared to 0.2 to the other groups. Both studies suggest a higher risk of drug-induced liver injury in the muscle D population, but as I mentioned before, these studies have some limitations, bias, like selection bias. We're missing some specific controls, and also the definitions of drug-induced liver injury, including the methods to diagnose the DILI in this population. And what happened in Latin America? Even I'm living in the US, but you can leave Latin America, but Latin America cannot leave you. So in Latin America exists the Latin DILI network, and they follow up patients for more than 10 years. And they report this year, they report the main characteristics of this cohort. And in around 468 idiosyncratic drug-induced liver injury patients, they identify 7% with underlying chronic liver disease. And 2/3 of that population have muscle D. And if you think this population, this frequency is higher than in the overall population, probably showing that individuals with muscle D could probably have a higher risk of drug-induced liver injury. Unfortunately, they did not make a specific assessment in individuals with muscle D compared to those who don't have muscle D. But I think it's a good proof of concept showing that this population could exhibit a higher risk of drug-induced liver injury. And this is complementary data from the Latin DILI, just to show you that they have 80 cases with a liver biopsy, and just in 2 of them, they identify an steatosis component. So even if drug-induced liver injury could be more frequent in the muscle D population, probably the phenotypes of drug-induced liver injury are not specifically linked to steatotic liver disease. And what happens with the metabolization of or the pharmacokinetics and in people with muscle D? Well, there are different mechanisms that can affect how medication works in your body, since you take the pill until this is eliminated through the liver. And this is because people with muscle D could have some delay in gastric emptying, specifically people with a lot of years of diabetes or people with obesity. There is some changes in the intestinal enzymes. Also, the gut dysbiosis can affect this, and they can have a different distribution. For example, a higher BMI. They can also have a lower glomerular filtration rate. And most importantly, in terms of hepatic elimination, people with muscle D can have a different abundance or a decreased abundance in important hepatic transporter, but also in protein levels of CYP enzymes. And this study is not directly involved in drug-induced liver injury, but they take a population around 90 patients with a liver biopsy, and they correlate the severity of the liver disease with the pharmacogene mRNA expression, and they identify notably changes according to severity of muscle D. So that's an aspect that can notably modulate the pharmacokinetics and elimination of some medications in our body. And this is also some supporting data of the most relevant changes in terms of CYP and transporter into hepatocytes that can modulate different effect for medications. For example, CYP2C19 can affect the clopidogrel effectiveness and metabolize many important medications like omeprazole or many others. So this is another factor that has not been so evaluated in the risk of drug-induced liver injury in this population. So some authors propose different mechanisms of injury in people with underlying muscle D. I mentioned that CYPs can be higher or lower according to the presence and severity of muscle D, but also some medications can induce mitochondrial dysfunction, and some medications can have relevant immunological mechanisms that can modulate this effect. So I think it's a moment to redefine what we categorize as cryptogenic steatotic liver disease and what we define as a drug-induced liver injury. Because in some aspects, probably medications can interact with other subtypes like muscle D. In other conditions, this would be a direct effect promoting steatotic liver disease. And in other cases, will be an idiosyncratic drug-induced liver injury. It's also important as in a clinical assessment in this population to rule out not only medications, but also the alcohol intake. As I mentioned before, 55% population could have an underreport of alcohol use. And even if evidence it's not so strong showing that alcohol can increase the risk of severe phenotypes of drug-induced liver injury, there's some data showing that people with acute liver failure of caused by acetaminophen can have a higher severity if that is associated with a higher level of alcohol intake. Cardiometabolic risk factors are relevant, but unfortunately, around 90% of the population fulfill the cardiometabolic risk factor criteria. So it's not so useful to differentiate between each other subtype, but we need to assess. And for sure, when we identify someone with hepatic steatosis, we need to stratify liver fibrosis risk. This is another framework that was suggested in a very nice review from 2023. So we need to identify alcohol, cardiometabolic risk factors, and liver fibrosis, but also we always need to think about pharmacological therapies that could induce drug-induced liver injury. And it's important to assess the temporal relationship. You know even more than me about this. We also need to assess the phenotypic characterization, eventually rechallenge. We can use RUCAM and RECAM scales, and sometimes we will require a liver biopsy. And there are some other frameworks to consider in this scenario. The typical drug-induced liver injury will present in an acute or a chronic way with multiple phenotypes, multiple symptoms, sometimes with no symptoms. And we know that more than 1,000 medications can cause this one. But in the opposite corner, we know that there are some medications that have a direct steatotic mechanism in the liver. And these medications can also cause or not symptoms. And the most typical medications are amiodarone, valproic acid, methotrexate, and tamoxifen, corticosteroids, among others. And muscle D, it's basically chronic, asymptomatic. We need to exclude alcohol, and alcohol-associated hepatitis. It's a very acute episode of toxicity due to alcohol, and it's typically a cholestatic disease. Not you can see steatosis, but the diagnosis can be made by using the NIAAA criteria. And when we see the diagnostic methods for the drug-induced liver injury, there's no specific findings in liver imaging, and the liver biopsy can show whatever you want, not necessarily just hepatic steatosis. In contrast, drugs that specifically induce steatosis will show hepatic steatosis in the liver, and some of them will show microvesicular steatosis, suggesting the mitochondrial injury. In contrast, muscle D will have the most typical features of steatotic liver disease, including balloon hepatocytes, apoptotic bodies, and other markers of inflammation. And I think it's important that realize that liver biopsy is not the perfect method to determine differences among groups. And at least in the muscle D field, magnetic resonance imaging with proton density fraction has become an almost gold standard to identify liver steatosis, and it's not affected by scanner field strength, patient factors, and concomitant liver abnormalities. So we need to probably change the paradigm of how we define and identify the liver injury in steatotic liver disease, including drug-induced liver injury. We're all crystal clear that we have to do a liver biopsy, but in the middle, we can identify several techniques like MRI-PDFF, but other techniques like DCT or ELF that are more available in Europe. And probably the rationale of use of these techniques can be very helpful to categorize the risk in this population. Other markers like CK18 by using M30 or M65, or the microRNA 122 could also be helpful in this scenario, but data is modest and we need more information to use them as a biomarker. But the concept is that we need to move from the traditional paradigm, liver biopsy, to non-invasive biomarkers. And regarding MRI-PDFF, it's important to notice that if you have steatohepatitis, you will have a higher MRI-PDFF. But if you have a decrease in over 30% from your baseline MRI-PDFF, that correlates with a histologic response in individuals with MASLD. So probably I did not found evidence on this in drug-induced liver injury, but maybe MRI-PDFF can be a very nice surrogate marker of inflammation and hepatic steatosis. So at diagnosis, we can do an MRI-PDFF, and at the follow-up, we can reassess this. And if we observe a drop, that can be a marker of good prognosis. So I think this is extremely important for clinical practice, but requires validation in drug-induced liver injury. And finally, I will just discuss some provocative findings in terms of how genetic risk interacts with some estrogen receptors, and some medications can modulate this. And this is a very, very interesting manuscript. I think it's one of the landmark manuscripts in the field that offers evidence that women tend to have a lower risk of or a protective risk of hepatic steatotic that it's loose when women get older after menopause. So they think that PNPL3 can interact with the estrogen receptor alpha. So they conducted multiple analyses in individuals, but also in cells, and they observed that the estrogens and females can have a higher levels of PNPL3, and that can modulate how PNPL3 is expressed, but also can explain why tamoxifen could have a higher impact in some specific populations. So I think this data show a potential benefit in the assessment of PNPL3 genetic status in those who will use tamoxifen or other similar medications. And that can, I think, requires validation, but probably opens a new area of development, considering that most of genes in drug-induced liver injury have been focused in the HLA. And finally, what happens with PNPL3 and other drug-induced steatosis medications? Well, this is a recent systematic review that showed that PNPL3 probably doesn't have an association or modulates drug-induced steatosis. But in individuals with diabetes, two medications, glucagon agonist, alomeglibant antagonist, and the basal insulin peg-lispro could have a higher risk of hepatic steatosis if they have at least one allele of risk of PNPL3. So I think this is a mix of things, but I hope you get the following message. MUSCLE-D is extremely prevalent, but usually coexists with medications that can injure the liver. And the identification in different categories of steatotic liver disease, it probably underestimate the drug-induced liver injury as well, other categories. Then there's a phenotypic overlap between some medications that can induce liver steatosis and MUSCLE-D. So that can be challenging and probably requires a refinement in the 2023 criteria. MUSCLE-D can also affect hepatic enzymes and transporters, so that can modulate the drug exposure and susceptibility to injury, specifically medications that are linked to drug-induced steatosis. And probably some drugs can have a higher risk in the MUSCLE-D population. As I show it, the evidence, MUSCLE-D could increase the risk 4 times of having a drug-induced liver injury. And novel assessments of genetic variants like PNPL3 are attractive. I think it shows that this is, we need to do more precision medicine, and specifically in medications like tamoxifen, the genetic testing for PNPL3 can be very helpful to estimate the risk of liver injury over time. And finally, I think we need to work in improving the borders between MUSCLE-D, DILI, and other subtypes, because there are multiple overlaps between this steatotic liver disease subtypes, but also because we can identify different mechanisms. There's people with genetic risks that promotes the liver steatosis by different mechanisms. There are drugs that can induce hepatic steatosis, and there are drugs that can cause idiosyncratic drug-induced liver injury. I hope you enjoyed the presentation, and this is what I wanted to speak today, and I'll be happy to discuss in the Q&A section. Thank you.
Thank you very much, Luis Antonio, for this great talk. Really provocative talk. Thank you very much. Fantastic. Let me start with some comments. For example, it's intriguing to me, the fact, because I'm working for many years in drug-induced liver injury, and it's intriguing to me the fact that, for example, the DILI registries are not enriched in pain with MUSCLE-D. These registries are registries of adult population. To me, is something that is unexpected. The fact that the registries aren't reaching instead with MUSCLE-D. It's true that data are lacking in many cases in order to characterize whether or not the patient has MUSCLE-D. But this is a first point. Second point is the pharmacokinetic changes you have mentioned that have been nicely shown in 2 or 3 recent studies, are not enough to explain the susceptibility, because idiosyncratic DILI is not so dependent of drug metabolism as can be expected, because there are other factors, several factors that interact themselves in order to produce finally the disorder. And so it's an interesting finding, but not enough to explain, the susceptibility, because only a small fraction of patients with these pharmacokinetic changes will develop DILI when exposed to the drug. But the findings you have mentioned, and I was wondering whether this, for example, PMP-L3 could be used, to predict, for example, a given patient who has to receive tamoxifen or methotrexate is something that is interesting to explore, no? To explore the positive predictive value of this genetic alteration if present. But I think that in any case, the negative predictive value is something that is also to be of interest, because in given circumstances, the patient doesn't have this genetic variation. You may point to, for example, to more to the drug or more to the metabolic alteration in some specific cases. But anyway, I think it's something that could be explored a little bit further. What do you think about that?
Thank you. Yeah, I definitely agree with all your comments. The first one, it's the characterization of muscle D. It's not well done in unfortunately most of cohort studies, because we usually don't assess all the involved determinants of liver disease. For example, in the cohort studies assessing muscle D, we usually don't assess strictly alcohol and medications, but conversely, in the registries of drug-induced liver injury, the methods that we use for muscle D or other steatotic liver disease subtypes, it's not so good. In fact, we usually don't characterize the presence of steatohepatitis, the presence of the fibrosis stage in most of them. And we really know that if you have a F3 or F4 and you have a muscle B, your risk of liver-related mortality, it's totally different to the other population. So unfortunately, registries needs a better characterization of not only the disease itself, but also the liver fibrosis stage and other relevant factors. And for that, non-invasive biomarkers can be very helpful, not only imaging techniques, also blood biomarkers, and sometimes in Europe, in fact, you tend to use more ELF and other biomarkers. And I think the systematic incorporation of these biomarkers can make us better understand what's going on. If people with muscle D itself is more susceptible, of if people with steatohepatitis or at risk of steatohepatitis or advanced fibrosis. We don't really know, because most of studies include populations with a small sample size for those objectives. The second aspect, I definitely agree. The pharmacokinetic changes probably explain a small fraction of the drug-induced liver injury, but I think it's a good aspect to discuss how an external disease, the muscle D, it's a metabolic disease, can affect how a medication is incorporated in your body, even if you don't have an advanced liver disease. And I think that's very interesting for further considerations. And about genetic risk and genetic testing, You can do a PNPL3 and it costs around $70 if you do a TACMAN. So it's something that it's not so expensive to incorporate in clinical practice. If you think about the cost of the chemotherapies or the cost of an hospitalization, this cost can be so high compared to a simple genetic test. But for sure, we need cost effectiveness studies that we don't even have in the muscle D field yet.
Yeah.
But I think it's interesting how we can translate the information from other steatotic liver disease subtypes and the genetic risk assessment for the use of medications that could have an impact or can induce steatosis in this population, especially if you know that someone with tamoxifen will use it by 10 years or methotrexate. So for us, I think it's something that we need to think about and maybe incorporate in further studies. We don't really know. As far as I know, there's no long-term comparisons with the cohorts and addressing multiple risk factors to know if PNPL3 can be so relevant. But if you have many options other than tamoxifen and you have a patient with high BMI with diabetes, but also high-risk PNPL3, probably it's not the safest medication to be initiated in that setting. So if I will start tamoxifen, I would like to know if I am homozygous or not. Yeah.
Yes, you are right. Thank you. Dominic has a question for you. Dominic Larray.
Congratulations for the talk. And I have two questions. One question is regarding acetaminophen, paracetamol, hepatotoxicity. There are some data suggesting are going for higher prevalence, higher severity when using acetaminophen at a relatively limited dosage. Do you believe that there are some data, some discrepancy across some studies? Do you think that genetics, for example, PNP, maybe have a role in the risk of developing liver toxicity with paracetamol in obese or patients with metabolic syndrome?
It's another good question and something that in clinical practice it's a hot topic because some people it's so afraid to use acetaminophen. Most of the evidence shows that acetaminophen it's safe, even if you are homozygous for the PNPL3 genetic variant. There are some unpublished data from our group. We are in Latin America. We have a big cohort of patients with steatotic liver disease that we are following over time. That's unpublished, but even people using acetaminophen chronically, they don't develop more severe phenotypes. But also, if you see the registries of acute liver injury in the areas with the highest frequency of PNPL3 high-risk variants, especially Latin America, you can notice that acetaminophen, even being a frequently used medication, it's an uncommon cause of acute liver injury or other severe hepatitis. So if you have to weigh the risk of different risk factors in clinical practice, for sure, alcohol, especially an excessive alcohol intake, has the highest risk compared to any other thing, even methotrexate, corticosteroids, any other. After that, diabetes. After that, BMI. In a smaller fraction, you can find other factors like hypertension, dyslipidemia, and some medications. In the case of acetaminophen, I'm not so sure that it's harmful in this setting and can be benefit from PNPL3 testing. And I hope to that That's clarifying. As far as I know, there's no other information, but we'll see. We can explore the Latin American cohort and see if there's some interaction there.
The second question was dealing with methotrexate, because there have been for 30 years a lot of data telling that methotrexate was the cause of liver injury, the cause of steatohepatitis, fibrosis, and so on, up to the time that HCV has been discovered and was at confounding factors, and also that it seems that methotrexate alone, without alcohol, without metabolic syndrome, was responsible for a frequent but mild increase of transaminase, but no more. For steatosis, it's not that clear, and the risk of fibrosis alone, there are some data suggesting it's not that harmful, but associated with steatosis, with a metabolic syndrome and so on, it might be more associated with higher risk. Do you, in these circumstances, do you think that PNP as well may be useful in this category, because it's a quite frequent administration?
Yeah, I think it's another good question, and deserves more research. But what we think, it's what we used to think in the 90s with the acute myocardial infarction and diabetes, that diabetes was an equivalent to acute myocardial infarction. So probably having a PNPLA3 GG over 40 years old could be an equivalent to have diabetes or other relevant risk factors. So even if there's no so much granular data on PNPLA3 and methotrexate, I think it's something that we should put in the balance to take decisions of use or not. For example, if you have a young patient with just a mild elevation of AST and ALT, probably that's not a big deal. As you mentioned before, that patient probably won't have severe consequences. But if you have a patient with an evidence of steatohepatitis or abnormal liver tests, and you identify an advanced fibrosis, that's a very bad patient to start methotrexate, right? But if you're in the middle and you have to take decisions, okay, let's see 6 months, 1 year, or whatever, I think that's probably the best setting to do a PNPLA3 testing. But it's not validated. Also, if you stop the medication, probably the liver injury will stop. So it's not a big deal if you don't plan to use it for several years. So I think can be useful, but for sure we need more information. But I insist that if you compare PNPLA3 to diabetes and obesity and alcohol, probably alcohol is the most relevant risk factor, even than other things. So it's better to be very strict in the alcohol intake and the control of metabolic risk factors than just be focused on the PNPLA3 genetic variant.
Thank you.
Thank you. Any other question? No, no more question. Okay. Thank you very much, Luis Antonio. It's been a real pleasure to have you in our seminars. Was a fantastic and exciting talk with really new data. I look forward to see you on Washington, no? Probably.
Yeah, I'll be there. So happy to discuss and collaborate in further initiatives. I mainly work in non-invasive assessment and in the development of some medications, but happy to collaborate because we need to integrate both different areas, steatotic liver disease and drug-induced liver injury.
Yeah, it will be a fantastic
I appreciate your invitation and looking forward to seeing you in Washington, and if not, in Barcelona.
And exactly. Okay, thank you very much. Thank you. Thank you all for attending the seminar. Thank you.
Thank you. Enjoy the rest of your day. Bye-bye.
Bye-bye.